So our next session now is about how we have been collaborating the last years with the WHO Rehabilitation Programme. And for this, I have the honor and the pleasure to present to you Dr. Wouter De Groote, who is a friend and colleague from Belgium, by the way, and he is currently, he's a PRM physician, and he's currently working at the WHO Rehabilitation Programme. And we also have Professor Maria Gabriella Ceravolo, who is a professor of PRM medicine at the University of Ancona. And also our director will join in the interview. I don't see your faces. Could you open your cameras? Perfect. Good morning, Maria Gabriella and Wouter. So welcome to our session. So I will start perhaps by asking Wouter to, because not everybody may be familiar with the work of the World Health Organization and in particular the Rehabilitation Programme. So perhaps we could start, Wouter, if you explain a little bit the aim and goals of very briefly WHO and then specifically the Rehabilitation Programme. Thank you.
Okay, thanks, Carlotte. Currently, the WHO is working towards the goals of what we call the Global Program of Work. So this is the 13th framework, which tries to achieve the triple billion target, which is 1 billion more people enjoying better health, 1 billion more people protected from health emergencies, and 1 billion more people benefiting from universal health coverage. And as you know, universal health coverage is about everybody having access to quality services in the promotion, prevention, treatment, rehabilitation, and palliative care according to their needs and without financial hardship. So rehabilitation is an integral part of universal health coverage. And to achieve universal health coverage, the Rehabilitation Programme at WHO is working towards the strengthening of the health system for rehabilitation. And almost all of our activities are about increasing two major pillars. One is the increasing the demand through awareness raising and advocacy. And on the other hand, increasing the supply by increasing technical capacity. So our team consists of about, and now I'm talking about HQ, of course, because of course we have the regional offices and the country offices that deal with follow-up in countries and implementation processes, while at HQ we are responsible of developing technical guidance. So our team, all of us are kind of specialized in health system building blocks. We have the workforce, the information, the governance, services. So we are developing tools and technical guidance to strengthen the different health system building blocks of WHO to enable the health system strengthening for rehabilitation. So concretely, this means, for instance, for the workforce, we have recently published the Rehabilitation Competency Framework with accompanying guidance on how to adapt the competency framework for localized needs or adapted curricula. We are currently working on a package of interventions for rehabilitation for the health system building block of services. We have worked on a DHIS2 module for the routine data collection in facilities. We are working on a basic package for rehabilitation in primary healthcare. We are working on a guidance document on how to finance rehabilitation for universal health coverage, and so on. So this is, in a nutshell, what we are doing. Thanks, Carlotte.
Yeah, that's an amazing package of work. How, coming now to the content of of our work in Cochrane Rehab about evidence, how does WHO try, or or include evidence in their work, in their guidance, in the production of products?
Yeah, and I guess this would very much depend on the type of product. First step would be to look and check whether there's any WHO guidance already existing that we can build on. And that is crucial from WHO perspective. We will not be developing tools and guidance from scratch if anything is available and that we can build on. Because anything that is produced newly will have to go through very rigorous processes and methodology. So always have a double check on available resources that are already produced by WHO. Then, of course, for instance, when it comes to global status reporting, these will be aggregate data, pooled estimates that are used in terms of the evidence, especially when looking at targets for the reporting on global tracer indicators. If it is about scientific briefs that are produced, we will commission new systematic reviews, or for any guideline in terms of the treatment or rehabilitation of a health condition, again, systematic reviews will be used based on the scope of the guidance document. Of course, we will use expert consultation mechanisms to ensure broad participation. There's even public hearing sessions. WHO might or may publish some resources online and ask for the broader society and community to respond and to reflect and provide feedback. So there's different types of information, let's say. It's not always the evidence. So public hearings are not evidence, but it's a type of information that is used to develop the resources.
Okay, thank you. Perhaps we will go over to Stefano now to give some examples or methodology on how up to now Cochrane Rehabilitation has been collaborating with WHO in providing and supporting with evidence in the different projects of the rehabilitation program. Thank you.
Yeah, thank you for the question. Until now, we had three main activities. One was related to the package of interventions for rehabilitation, and there we have been involved in the helping in the development of the methodology, so to make the quality of the evidence coming from the systematic reviews on the 20 health conditions that have been selected by WHO to define the package of interventions for rehabilitation, that I remind you is something that will be given to the different countries as the minimum set of interventions that should be available in each country to provide rehabilitation to the population. And we coordinated 10 of the 20 groups in extracting all the current evidence from the clinical guidelines. So clinical guidelines obviously do not report only evidence, they report evidence and expertise of the commission that developed the clinical guidelines. So we extracted all that material, and we extracted all the material from the Cochrane reviews on those 20 health conditions. That was one and the first big project we have run with the WHO Rehabilitation Programme. And then we had the huge work that we performed around COVID-19, around the pandemic. The first one was the selection of the research questions that have been published in the Archives of Physical Medicine and Rehabilitation. That is a combination of questions about epidemiology and about the evidence at different levels: micro level, that is the individuals; meso levels, that is the health services at the local level; and then the macro level, that is national health services. And that is part of the work that Maria Gabriella is doing, and she will present us. And then we also worked on the production of evidence relevant to the COVID-19 emergency. So one was about the sequelae of COVID-19, of the acute disease, and at the time in which what was then called long COVID and now is called post-COVID-19 condition, according to the WHO, was not even known. So we were producing about the sequelae of coming out of the intensive care and of the extubation, etc. And that was also part of the Cochrane Library Special Collection. And now we are working on the post-COVID-19 condition, extracting all the evidence available on that specific topic for an interim guidance that WHO is producing. So in fact, we are very proud of the partnership with the WHO Rehabilitation Programme, and we try to do our best because it's totally complementary to our action. Our action is to produce evidence. The action of Cochrane, of the WHO Rehabilitation Programme is much wider, is to work with the governments, but they need our evidence to work at best. So this is what we try to do at our best as much as we can. But okay, I will stop here. I will not present the part of, but Gabriella is doing, and she knows much better than me.
Yes, perhaps indeed we can now ask Maria Gabriella to explain a bit more about the Recover Action that we started last year quite soon after the start of the pandemic. And then I will go back to Wouter for some questions that came up listening to the previous sessions. Please, Maria Gabriella.
Thank you, Carlotte, for this question. I believe that the joint action between WHO and Cochrane Rehabilitation was really important. It was effective and it was very rapid because at the end of March 2020, when the pandemic hit very severely Europe, this action, Recover Action, that means Rehabilitation COVID-19 evidence-based response action, was launched, and it consisted of 4 different tasks. The first one was the definition of research topics on rehabilitation and COVID-19, because I believe, as Stefano has correctly told us, that whereas WHO, of course, is concerned with very wide actions and with the governance, with the achievement of standards in the care of patients. So from WHO, we took the perspective about what topics are most relevant to be taken care of. So the definition of research topics was done together with WHO and focused in this case on both epidemiological concerns and the search for the best rehabilitation interventions to care for people suffering from the sequelae by COVID-19. The main responsibility of Cochrane Rehabilitation was to provide an effective and reliable methodological approach in order to extract evidence from scientific literature. And this was a very sensitive issue because in March 2020, we were at the start of the pandemic in Europe, and although only 4 months had elapsed from the first patient described in Wuhan in China, a lot of papers had already been published, even if their methodological quality was not very high. So the decision by Cochrane Rehabilitation was to launch rapid living systematic review, thus availing of some technical terms or some approaches that Cochrane had already used in the past because rapid reviews and living reviews are allowed in a very dramatic context like the one that the pandemic got us experiencing. So rapid review means that the research information from the scientific literature are compelled to synthesize all the news concerning a specific topic very quick in order to feed the scientific community and the clinical partners with the best available evidence on how to manage, how to face the challenges imposed by a new health condition. And living, of course, is another big responsibility, because as far as the quality of the scientific literature improves and also the amount of information increases, new systematic reviews have to be published. So in order to face all these challenges, the Recover Action led to the publication of the first systematic review on rehabilitation needs and COVID-19 in April 2020. The review was updated monthly, and currently we have arrived to our first edition of the Rapid Living Systematic Review. Please, Carlotte, stop me at any time if you feel that I have answered your question, and maybe I can be more specific in case you need more specific information from me.
I think this already gives us a good idea of what has been happening, and if people have questions, please put them in the question section, and we can get back to it also afterwards.
Yeah. Okay.
One thing I was thinking, Wouter, during the previous sessions, I don't know if you were able to join them. We know that the WHO obviously works for health worldwide and with a specific focus on low middle income country. We heard in the previous sessions about the big problems in those countries, specifically when evidence that is provided is not or available or adequate for people in specific contexts. I don't know if you could elaborate a little bit on how WHO manages this problem, because we all know that most of the evidence is produced in high-income countries, but how then to tackle this problem, to make it applicable? I have some ideas of how it was done in the package of interventions, but perhaps there are some general guidelines, because this is a huge imbalance between the production of the evidence and then where it is needed to start working, and to often we start from scratch in some countries, as we heard previously also from Abina. I'm sure also with your personal experience in Africa that you could have some ideas on that.
Yeah, and it is, yeah, and I'm looking at WHO processes, of course, and indeed, when developing resources, guidance, documents, we do have these processes of involving the different WHO regions and experts that are consulted to make sure that their voice is heard. And for instance, when now developing the rehabilitation guidance for post-COVID-19 condition, we have these experts from around the world. When selecting interventions or providing recommendations, we have included this these features to and how which criteria to use when select interventions. And there is the applicability that is global. There is the feasibility, which doesn't mean that we should move away from the evidence-based guidance. But there should be this contextualization about applicability and feasibility. or at least experts providing some background information when in a resource limited setting, how to deal with the recommendation that has been given. So I'm very confident. My experience is limited, but that WHO, whatever is produced, makes a lot of effort to make sure that it is applicable globally. Mm-hmm. Does this mean that it is fitted to every context? That I'm not sure, and I would agree. There would still need some efforts to be done at a country level, and that is usually and often happening when products are produced, that regional offices and country offices use their own capacity, contextualize even more to the local context when it comes to translation to the local language, and then applicability considerations. I'm hoping that is answering your question. Yeah.
Yes, it is, and it's a little bit the experience I had when collaborating on the package of interventions, where we had some evidence-based interventions, but then we also had in these consensus meetings where there were experts from all the world, from different regions and different professions, the sometimes quite intense discussions whether to include or not, also for low resource context, because it's also a little bit an ethical problem, because we cannot, in my opinion, continue on having a world with two speeds. So there was often the discussion not to be too exclusive either, because otherwise it's a vicious circle. If you keep saying something cannot be done in a context. So there was this discussion of still including, also to stimulate ministries also to invest in rehabilitation. So there is quite a big ethical aspect on this. I don't know if you want to comment on that, or if other panel members, I know that also Maria Gabrielli was involved in some packages, if they had the same problems. I was, for example, in amputation, then when you go to types of prosthesis, like, okay, you cannot keep saying because it's not available that it should not be used. Anyway, it's also in some areas in Europe. We're talking now about there are also big differences in Europe, for example, all around the world. So there's this ethical aspect also that is quite important.
Yeah, and I in terms of, like, indeed, I mean, when there's some evidence base for a specific product to use or an intervention, it should be recommended and be aspirational, adapted to local context. And that is some of the efforts when looking at the broader scope. When for instance, last week I was in Rwanda for strategic planning, we would have the same discussion, but then discussing how safety standards will need to be developed, quality standards. So uprising and scaling up does involve this this type of recommendation that need to be achieved, even if in a limited resource.
I think one of the tips we had also from Farouk and Abena before was we can also save some money de-implementing treatments that are also costly and that don't have evidence, or where there is evidence that they don't work specifically. So that could be also important.
That is not only for low middle income countries, no, exactly. I must say, yeah.
Exactly. Yeah.
May I add something, sure, Carlotte?
Please,
because
please.
I believe that under the clinical and methodological point of view, it is the responsibility of the WHO and possibly of Cochrane in general to show what interventions are really effective, irrespective of the cost, because it is up to governments to decide how to balance the problem of the costs. We saw it with the vaccination now. So of course, vaccination is not available because it is very costly for low-income countries, but it is under discussion the possibility to renounce to license for diffusing the vaccination. So it could be also a policy that the one to decide about what interventions are really effective, and then discuss the costs and how to make them available also in low-income countries. I agree with you that is an ethical concern, but about ethics, governments should take care of this issue, not the scientists. It is not up to now to discard interventions only because they are too expensive. They are expensive based on the law of the market.
Yeah, and then there is the aspect of cost benefit, because something can be expensive but have a large benefit and a return on investment. So it's very, very complex.